So I want to talk a little bit about today about the portal venous system. Has more specifically how we image the portal vein, what we're looking for, how to spectral and color Doppler it, and how to interpret those Doppler readings. So the first thing you may remember from anatomy class, when we think of veins, we normally think of them as bringing blood away from an organ. Arteries bring oxygenated blood to the organ, veins bring the blood away back up to the heart and lungs. Um, Portal vein is going to be unique in that it actually is bringing blood to an organ, that organ being the liver. Um, the first thing that we want to look for in a portal vein is its size. When we go to measure the portal vein, we're going to measure it inside wall to inside wall, and that measurement should be less than 13 millimeters. If it's greater than 13 millimeters, that's going to be a pretty good marker for portal vein hypertension. And portal hypertension is going to be an increase in blood pressure within the portal venous system. So that makes sense. If you think about it, if you have an increased pressure inside of a pretty pliable tubular structure, as that pressure is pushing out, it's going to be pushing those walls out and eventually over time making that vessel bigger. So that's one of the first things we want to look for is what size the portal vein is. Most commonly, portal hypertension is going to be caused by intrinsic liver diseases, hepatitis, cirrhosis, hepatocellular carcinoma, those kind of things that are coming from within the liver that may, if they're developing scar tissue from cirrhosis, it could be compressing those vessels, causing the inside pressure to be increased. There are some extrahepatic things that can happen that can cause portal hypertension if they have a blockage in their IVC, if they've had prolonged congestive heart failure. Another indication could be if they have portal vein thrombosis. They can actually have thrombus within the portal vein lumen. With ultrasound, we can actually see that most times. We'll see a blood clot within that lumen. Indirect, if we're not able to actually visualize the portal vein that well, especially if it's blending in with the other echotexture because it is clotted off, other indicators could be a quick increase if they have ascites, recanalization of the umbilical vein, where our ligament arteries are a remnant of our umbilical vein. We would look in that area and it actually open up because your body is trying to make a new way for that, a new pathway for that blood flow. Splenomegaly can also be a indicator of that. Collateral vessels and reversal of blood flow, which is something we're going to talk about more in a second. So another thing with portal vein thrombosis, you can get what's called cavernous transformation. That's going to be basically varicose veins. They're going to be more in that porta hepatis area. You're going to see a lot of collateral vessels because your body is trying to make a pathway for that blood to go since it's blocked off where it normally would flow. Every time we evaluate the portal vein, we want to do two things. We want to put color Doppler on it and we want to put spectral Doppler on it. So for color Doppler, in most cases, as you remember, the blood's going to be delivering, or the portal vein is going to be delivering blood to the liver. So that blood is going to be flowing towards the liver. That's what we refer to as hepatopedal flow, and that's the normal flow for a portal vein. Now, if they have pathology, if they have portal hypertension, let's say, then the blood flow is going to actually reverse and be going out of the liver because it's blocked from going where it needs to go. And that's going to be referred to as hepatofugal flow. So that's going to be flow away from the liver. So when we put our color box on the portal vein, we're going to put it at the porta hepatis, right where it's entering the liver. And in most cases, it's going to be red blood flow if it's normal hepatopedal flow. Now, with that being said, there's two really important things that we need to remember whenever we're putting color Doppler on our vessel. One is to always check your color map. So if we have our color map flipped and we have the blue as the flow on top that's going towards our transducer, it's going to appear to the radiologist that they have a reversal of flow when they don't. So you always want to make sure that your color map is correct. Second thing is that you're using correct technique. If your probe is backwards, it's going to make the flow appear backwards. So if you are getting your nice long portal image vein more transversely, you want the notch to be towards the patient's right side. If you're getting it more in a sagittal plane, your notch should be towards the patient's head. When we put on the spectral Doppler, let's say this is our baseline here. Normal hepatopedal flow is going to be above the baseline. And conversely, if you have hepatofugal flow, it's going to kind of go below the baseline. So that's something that we look for. And this is pretty similar to what it's going to look like. It's going to be a low velocity flow. So it's not going to be, you know, all the way up here. It's going to be towards the baseline. Monophasic, meaning that it's not going to have high peaks and valleys like we'd expect in an arterial flow. And it's going to have a little bit of this undulating appearance. It's not going to usually be perfectly flat. That's due to the patient's breathing, respirations. As they breathe in and out, we're going to get this kind of wave-like pattern. If you have them hold their breath, you may still get a wave-like pattern just from the pulsatility of their heart. So this is something that we're going to look for with the spectral Doppler. So that pretty much sums it up. As always, with everything with ultrasound, it's very operator dependent. So you want to make sure that you're vigilant and using the proper techniques.